As with any first-time endeavor, I know that there were a number of hurdles that the group in getting CQIP established in Saskatchewan had to overcome, and I'm sure each of you, both as participants, coaches, support to these projects, also had to overcome. And so I want to thank I guess I'll start by thanking all of the people from our partners, along with the ministry, with Health Quality Council, with the SMA, and those organizations, regional health authorities and others who have supported getting CQIP off the ground. And I also, of course, want to congratulate and thank the 15 physicians who completed the first cohort of the CQIP, and a huge thank you to all of the faculty members and coaches as well. I understand it can be very challenging for the physicians who have taken time out of your busy schedules to participate in the training program as learners, coaches, and faculty members. Physician training and clinical QI skills and methodologies have been identified as one of the key foundations for building our system's capacity for advancing appropriateness of care in Saskatchewan and moving our system to becoming a high-performing one. Over the summer of 2016, the appropriateness of care team met with CEOs of individual health regions, senior leadership teams, and with physicians and our physician partners across the province to talk about how do we collectively move forward with appropriateness of care. And we heard loud and clear at the meetings that without physician leader and involvement, appropriateness of care and moving to that high-performing system can't be achieved. So, of course, in Saskatchewan, we've been undergoing a continuous improvement journey really over the last number of years. And we've had a number of early adopter physicians who've been part of that. But if we're going to move this and advance the quality of our healthcare system, the safety of our system, the appropriateness of care, we need to move beyond those handful of early adopters. And I certainly want to extend my appreciation to them. Some of them are your coaches and the people who have helped to bring this first CQIP cohort together, but we really did need to move beyond having a handful of physicians who are trained, who understand, and who can support others in leading quality improvement work, in leading work around quality, safety, appropriateness of care, and make that really a movement right across our system and across our physician community. I guess the other important thing, and I guess we'll hear more about it later today, is based on that first experience. It sounds like there is some good word of mouth and some good experiences being relayed to others. And we had, as I understand it, 37 applicants for the second cohort of CQIP this year, which I think is a really positive message, and again helps us move down that road to having a small group to this starting to become sort of moving up the bell curve here. So with increased involvement of our clinicians and appropriateness of care and adequate support provided to those physicians leading this work, our goals can be achieved. Things like reducing unnecessary testing and treatments, providing effective care that's scientifically proven, that has scientifically proven value to patients, getting rid of some of that underuse of effective care, reducing patient harms as a result of medical errors, and reducing clinical variation so that patients with similar conditions receive the same level of care no matter where they live. And I think this is all especially important now as we are moving to that single health authority and the idea of trying to eliminate some of the variation and inconsistency that we see right across our province. So again, congratulations. My apologies if I've repeated some of all of what the preceding speakers have talked about. I didn't get a chance to compare notes with them beforehand or to hear what they had to say. And so I really do look forward to hearing about your work, your projects, your experiences, and being part of the day with you. Thanks very much for inviting me to help open the session.
With that, I am going to turn it over to Jason to kick off the rest of the morning.
Good morning, everyone. I think I'll start with I'm Jason Ozane. I'm going to start with a confession. I have been exercising my QI muscles, but I do occasionally skip leg day. So it's time for us to let the participants show off what they've been working on for the past year. So we're going to start with a quick round we call QI Talks. This is what Quick Talks is to QI what Iron Chef is to cooking shows. Participants are going to be given a very brief amount of time to give you a high-level overview of their project, specifically 3 minutes and 30 seconds. Now, they're not going to be able to get into tremendous detail with this, but that's why we have the posters. And this afternoon, you'll have lots of time to go look at the posters and talk with the participants in depth about their projects. But this is a very quick, high-level overview of what they've been working on. Who's our timer? Well, I think we need someone a little more intimidating because we're going to be very strict about time. So 3 minutes and 30 seconds isn't a lot of time, but this will be exciting because the participants will get to showcase some of the work they've been doing. So I don't have the list with me, but I believe Dr. Milo Fink is our first. Are you our first speaker? Oh, thank you. Yeah. Yep. There you go. Come on up.
Okay, so I can, is this how I move I just press the plus and it goes? Okay, all right, this project, this doesn't work. So next slide. Well, this one here that has arrows. That one. Okay, so this started. Right. Anyway, I'm the head of medicine for about a year in Regina, and so this is looking at the medical issues around transfers or handovers. So complex patients are in internal medicine. A safe handover requires information to get transmitted. The discharge summary is how you do that. And by the way, that's also a provincial priority, discharge summaries and medication discharge reconciliation. So what we did was to, first of all, start with looking what there is, and I personally reviewed all the discharges from internal medicine for a week and documented quality. Was happy with the quality, actually, but the issue was timing of when the discharges were made. So we had some iterations in terms of how we looked at it in larger groups over time, the PDSA cycles for the data collection. And then we focused in using some of the things we learned here in terms of a run chart. So you can see this is a run chart, and the important things are that it's January to September when we last collected the information. Group 1 contributes 80% of the errors, so discharging dictating anything later than the day of discharge is a defect. And so Group 1, 80% is defect. Group 2 is good 20%. And this one is the report going to a particular position in the cohort of internal medicine. So you can see that particular position had quite a bit of variability. I haven't figured out why yet. So here is the group. So you can see in group 1 there was a lot of variability. This is the report that I'm intending to be sending to the physician who had that way out of line. These are your discharge summaries that you didn't do. Please do them right now. So opportunities, data for discharge, dates. That was really hard to find. That was one of the learnings. It's hard to actually get the data from the system to be able to send these report cards. One of the concepts in the Pareto principle is, the 80-20 rule. So we looked at the 20, I can do that. So the 1 minute left. So 80% of the worst, so we're going to flip it around, and in fact, the one you saw was the single physician who represented 20% of the worst performing. So interesting. The information capture is where we spend our PDSAs. We haven't actually sent feedback. That's the next step. We're looking at automating the data gathering so we can replicate in other departments. We need to work with the physicians, and I'm done.
And just a reminder to our participants when they come up, because we have people watching on the internet, if you can kind of stay in your box and part of the code. Right.
They can see you? They told us they can.
They're just listening in, right? Yeah. Oh, just stay in your box.
Okay. Oh, we're already on to next steps. Perfect. I'm, or no, this isn't me. How do I go back? Okay. I'm Coco Sinclair. I'm one of the interventional radiologists at St. Paul's. My project was around using ultrasound for follow-up of endovascular aortic repair, so EVAR is what I'll call it, just for short, because we don't have time. Background, so EVAR is used to repair abdominal aortic aneurysms. It has largely replaced open surgical repair, decreased morbidity, mortality. It's a fairly well-accepted way to treat these patients. Though unlike open repair, patients who get EVARs do need lifelong imaging follow-up. So this is just the state of the number of EVARs we've done in the health region. In 2012, we did about 2, and now we're up to year-to-date 2017. We've done about 63 EVARs in health region. They're done by both vascular surgeons and interventional radiologists. Between 2012 and 2013, we got a new vascular surgeon, so you'll see that that is where the jump came from. So here's just an example of what I'm talking about when I'm talking about follow-up. So here is a CTA, and there's IV contrast in the limbs, these two little circles. That's the EVAR limbs. Here is contrast outside, so this patient has an endo leak. On Doppler ultrasound, you can see this, the same thing very well. You see contrast blood flowing, or sorry, not contrast, blood flowing through the limbs of the EVAR. Then you see there's also blood flowing outside of it, and it's actually being fed by this little artery, the inferior mesenteric artery. So currently in the health region, we do exclusively CTA follow-up of these EVARs. Ultrasound is a proven way to follow these up safely after 12 months. So my project was to develop a program where people who can appropriately be followed up with ultrasound are transitioned from CT to ultrasound follow-up. Decreased ionizing radiation, decreased IV contrast. It's also cheaper. That wasn't the whole point. So it's an appropriate way to follow these people up. So I thought it was very easy. I'd roll into a meeting and everybody would praise me and they'd say, let's do it, no problem, appropriateness, decreased radiation, great. Did not happen that way. First mistake was I went to a meeting without any data and I just said, let's do this, and everybody assumed that there would be hundreds and hundreds of ultrasounds that would be needed to be done. So I got an immediate no from the managers of the ultrasound techs because there isn't enough techs in the hospital. Next thing I did was develop a program to train the technologists in the community clinics because there's capacity there. So I worked with one of the techs, we developed a program, had some volunteer patients come, we scanned them, but then we realized that really these studies should be done by experienced ultrasound technologists and experienced radiologists that are experienced with vascular ultrasound. So that was a failure. Well, not a failure, I learned from it. Third thing I would have to come up with was a way to get these things done in the hospital. And so I tried to come up with a way to streamline the ultrasound technologist workflow in the hospital. For about 1 week, it was a glorious week. Everybody was happy, the techs, the radiologist at St. Paul's Hospital. But then again, somebody who doesn't work at St. Paul's Hospital caught wind of it and shut it down because I didn't ask for permission. Again, it was my fault, but I just wanted to do it. After Paul Chisa came and said, just do stuff, I started just doing stuff. Yes. And the other thing, I'm almost done, and I will give Carla some benefit in this. She was helping me with my charts because I'm not that good with Excel, but I had been presenting the data as how many ultrasounds are we doing, how many CTs are we doing. Her idea, or the idea of the CQIP staff, was why don't we frame it as let's track the number of inappropriate CT scans. So I went back and looked through all of the EVAR follow-ups that we did for 8 months. We did 101 EVAR follow-ups in 8 months, so the volumes aren't as high as everybody assumes they're going to be. And of those 101, of those 101 CT follow-ups, about 46% of those were unnecessary. They could have been done with ultrasound. The word inappropriate still is a bit hurtful to me, but it could be like deemed inappropriate CT scans. Anyway, what's next? I won't back down, like Tom Petty, and we're going to continue on. And I have some ideas of where I went wrong. Maybe asking permission is a good idea. one unexpected improvement, and I forget Dr. Shaw or Guter, everyone was talking about the changing the culture. And when the CT techs caught wind of what I was trying to do with ultrasound, they said, well, we're inefficient. We want to do something too. So so we came up with a plan, and you can come talk to me about it. But I found a screwdriver and screwed this into the wall of one of the offices. It's a folder that just says add-on recs to protocol. And it's amazing that that one little thing has completely changed the way the techs work. They're way more efficient. We're happier. No one's fighting as much at St. Paul's. Anyway, so that was an unexpected outcome, and I think it's because the culture, people are thinking of ways to improve. Anyway, that's it.
Okay. Senthil Damodaran. So thanks. I cannot ignore the time now. Thanks, Steve. Yeah. So today I will share some attempts to reduce the wait times for children to get treatment for their mental health disorders. Okay. So, but quite a few transitions. So it's going to take time. So it was in the news recently that how parents are upset. The kids can't get treatment, and the government commissioned report, and the person went around and essentially heard the same thing. Parents are upset. They don't know what to do. Just sitting on the wait list is not helpful. And the report does identify that we need to work differently because we're not going to have enough bodies to deliver the consultations required. So it's just a good understanding. So, for example, over 8% of children have asthma. We do a good job of treating asthma in children, but number of children with mental health disorders is quite high, actually, much more than kids with asthma. And this is a significant change. We are seeing a lot of children in the emergency room setting, almost 50% jump the last 5 to 10 years. So most of our child psychiatric time is taken for providing acute care. So a lot of kids sit on a wait list. So we are very good at getting patients to the wait list, but not very good at providing them treatment. So if our number says that about 20%, 17 to 20% increase in the last 3 years in the acute care settings. So that means we don't have that much time to provide outpatient care. So it's not new to us. It's not. So this problem exists all over, especially in the U.S. And they have done other programs like, access programs of child psychiatry where psychiatrists reach out to primary care physicians and provide consultations. And there are trials which has shown that integration of mental health in primary care has shown to deliver improved outcomes. So we thought we could partner with local pediatricians. That's how this project started. So as a part of this project, we looked at the referrals for last almost a year, and we noticed that quite a number of patients, especially diagnosed with ADHD, could be seen by pediatricians. So when I'll describe the process in the next slide. When the improvement process started, actually we started using for all diagnosed, not just for ADHD. And to do this properly, we interviewed pediatricians, psychiatrists, made sure we had the parameters set out and agreed upon. So this is just a slide to show that we did the proper engagement process. But as things would have it, we had this improvement happened spontaneously. So this is the new process which started. So for example, the family goes to family doctor. So they think the patient needs mental health psychiatric consultation. So refer to mental health services or child and youth services. The intake person gets a referral, calls the family, gets information, more information than what the family doctor write in the referral note, discusses with the psychiatrist, and then the psychiatrist calls the family doctor, primary care physician, who refers, pediatrician, primary care physician, nurse practitioner, doesn't matter, who refers, we provide a first telephone consultation. And then with that information, the family doctor can treat the patient if they feel comfortable. And if they're not comfortable, especially for ADHD, they want a in-office consult. We had 2 pediatricians willing to see ADHD kids alone in their office, so they were referred there. And of course, all these processes were relayed back to the family doctor in a typed consult note. And Of course, doesn't mean we'll shut down the doors for direct consultation. We did see quite a few direct consultations as well. So, the 2 months, we had 48 patients gone through this process. So you can see nearly half of them had only indirect consults. 4 of them actually diverted to a different process, like psychology or something else. So instead of waiting just in psychiatry, it is only to be diverted to psychology. Later on, they were directly diverted to psychology. And you can see about 5 of them are seen in the office. So out of 50, 48, only 5 required direct consultation. So this had a dramatic impact on the wait list. So we are running around 30 to 40, 50 depending on the month. But the last 2 months, the wait list, not times, wait list dropped to 13. So what we learned, it's just not enough to work harder, you have to work wiser. Without access, no quality. Just sitting the wait list doesn't get anyone any better, right? So we need to provide treatment as early as possible. And of course, partnerships are the key. Thank you.
Okay, I'm going to set my timer here. I've practiced this, so I should be able to do it in 3.5 minutes. All right, good morning. I'm Henny Reese. I'm a pathologist in Saskatoon. Thank you for providing me with the opportunity to talk about my project, the development of a breast pathology subspecialty model in Saskatoon. So, pathology reports are used to make important treatment decisions, and breast cancer pathology reports provide essential information and contribute to the management plan of breast cancer patients. Poor quality and incomplete or delayed breast cancer reports impact the quality of patient care. In the past, breast cancer cases have been reported by general pathologists here in Saskatoon, and the quality and turnaround time of these reports has not been monitored. I wanted to develop a subspecialty service model for breast pathology because I believe that limiting the reporting of breast cases to breast pathologists with special expertise or training in breast pathology would improve breast patient care. I also decided to measure and monitor the quality and turnaround time of breast cancer pathology reports. Using a questionnaire, I asked my pathology colleagues to self-identify as breast pathologists. If they had an interest in or special expertise or training in breast pathology and wanted to become a member of this specialized service, they were to indicate this. I assessed resection specimen reports for a variety of quality indicators, such as, was the appropriate cancer reporting template used? Were all essential reporting elements included in the cancer report? Which and how many immunohistochemical stains were used to help diagnose the cases? And how many internal or external consultations were needed before the final report was issued? I also measured various turnaround time intervals for these cases. After the implementation of the model, the vast majority, actually almost all of the breast cases are now being reported by breast pathologists. The quality of these reports is improved. The correct template is being used and all essential elements are consistently reported. The usage of immunohistochemical stains is now significantly reduced compared to prior to the subspecialization project. We now use 50% fewer stains when reporting large resection specimens. This translates into a saving of more than $3,000 a month for these types of specimen alone. In addition, our reporting turnaround time has improved significantly. Subspecialization in medicine is becoming more common and necessary. The exponential increase in medical knowledge and the ever-increasing workload make it virtually impossible to stay competent and efficient unless you're specialized. The need for subspecialization in pathology is no different. We know that in other pathology departments across the country and the world, specialized pathologists can issue high-quality reports quickly, need fewer resources such as immunohistochemical stains and consultations, and provide better patient care. My project shows that this is also now the case for breast pathology service in Saskatoon. With the appropriate resources, this model could be applied to other pathology specialties. Thank you.
Good morning, everyone. I'm Marcy Hagee, a family physician from Yorkton. And as you will find out in my project, I also work in our Yorkton Regional Health Center emergency room, which is run by family physicians in the community as well. So my project was focusing on improving management of COPD exacerbations in our local Yorkton ER. So why I chose this project? So as working in the ER, I have noticed that there had been a perceived high frequency of visits to our emergency room for exacerbations of chronic obstructive pulmonary disease, or COPD. And this is a chronic disease that is ideally best managed by family physicians in their office. As well, there are tools and steps that can help these patients to actually self-manage these conditions. Also, we have the highest smoking rate in the province in our health region, unfortunately. So we're just under 30% in Sunrise. Saskatchewan itself is actually one of the higher provinces as well too. So nationally, we're just above 20%. In Saskatchewan, we're just around that 25, and like I said, in Sunrise, we're just under 30, unfortunately. So when we looked at some of the data and why these patients are presenting to the ER, one thing we did find is that we do have an advanced population in our population in Yorkton. And also there's multiple comorbidities in addition to COPD for these patients. Current smoking was also a factor. As well, we found that there was a lack of referral to community resources, which can really help these patients to self-manage their chronic diseases. And that was where we chose to focus for my project. So my specific aim was to increase the referral rate of possible COPD patients. So even if they didn't have a confirmed diagnosis or they had never heard about this disease before, they could be referred from the ER to our community pulmonary rehab program. And my goal was to increase it by 50%. And I chose the number of about 5, which I will go over in the next slide, 5 per month by October. So this slide just shows the 6 months prior to the CQIP project starting, what our referral rate was like in total. So this is not from the ER. There was 0 referrals from the emergency room. So to do 50% of 0, my project was done. But on average, we did only have about 3 referrals per month, unfortunately, going to our pulmonary rehab team. When I looked at our cardiac rehab program, which is actually run by the same clinicians, they were getting about 30 to 40 referrals per month. So there's quite a lot of difference between the two streams. So why the poor referral rate? In my improvement team, we were discussing the pulmonary rehab program and other community resources, and I got a lot of faces that looked older than this, but similar to this. There was a lot of, we didn't know we had this resource, and who does this, and how can patients get involved in it? So that's where we focused on, just getting information out. So we updated the referral form so it was A, present in the emergency room, B, it was easy for ER physicians to use, provided education to the RNs, respiratory therapists, and the family physicians who work in the ER, as well as to actually home care. We did a little bit of education with them too, because they work very closely with their COPD patients. We also created a COPD outpatient prescription to hopefully have physician buy-in to referring these patients. And how we did, you're going to have to come see my poster. But in a snapshot of our patient representative, his last comment at our last team meeting was, "It took so long for me to get my vitals done, and there wasn't enough time for stretching. It was so busy." So thank you.
Shem Fakhri, pediatrician from CQIP. As you can see, the first 2 names on the slides are very, very difficult to pronounce. Anybody who can pronounce this correctly will get a prize at the end of the day. This is a slide which will go into archives because this will be history. There are no regions now. But I'm from Cypress Health, and Cypress Health has done something marvelous in the last few years in terms of quality improvement. Ladies and gentlemen, quality is continuous. All the time we talk about quality, we talk about improvement, we talk about patient safety, and clinical pathway is one way of improving quality of care? And that was the main question to us most of the time in SIFCON, because we have tons of pathways, something lying somewhere in the archives, in the electronic medical records or in the files, but nobody was using it. So we are just concerned about what is the reason why when we invest so much of time and energy and nobody is interested to use those pathways. So we selected a clinical condition where there was a lot of variation among hospitals, among provinces, and among countries, and that was acute bronchiolitis in children. The intention of the project was to reduce the use of chest X-ray and respiratory swab by 50% by the end of 2017. And the reason for action was there was significant variation in the management of acute bronchiolitis in children. There was a lot of use of chest X-ray and respiratory swabs in the management. Physicians were not using evidence-based clinical pathways. There were barriers in using clinical pathways, and there was lack of organizational support. So that is the journey that we started to use acute bronchiolitis pathways. We aimed at 50% reduction in chest X-ray and respiratory swabs. We developed locally owned bronchiolitis order set, intensive engagement, education and training, and chart review weekly. Physician order set went through 4 PDSA cycles, and there was a definite ownership and willingness to use, and finally changes implemented. Physician order set has wide acceptability, and 3 patients in the month of October did not have chest X-rays and respiratory swabs asked for the management of bronchiolitis. Now, one of the things which opened my eye was when I was talking about acute bronchiolitis to a few family practitioners who were working in the ER. 2 of the young family practitioners, they came to me and they said that, Dr. Fakir, you are sitting at 2 o'clock, you are sleeping at 2 o'clock in the night, and you are asking me to manage a 2-month-old baby at 2 o'clock in the night. I have just graduated. It's been 6 months that I have been working in the ER. A baby who has got a respiratory rate of 80 per minute, look very, very sick, and you are asking me not to do chest X-ray, not to do CBC, and not to send swabs. And that was an eye-opener. I thought that perhaps he's right, because he has not been exposed to. CPS has made guidelines. They have just posted it. But they have not invested anything into using those guidelines and using those clinical pathways by those who are working with the end users. And that was a thing that I thought that perhaps I have to invest my time with these young physicians. And I said that, okay, once you get to acute bronchiolitis, you don't have to see that what's the time. You call me. I'll come. I'll sit with you. I will invest my time, and we'll let you know how can we manage acute bronchiolitis in young children without asking chest X-rays and swabs. And I will show you the same child 24 to 48 hours later, and then perhaps you will get some confidence in managing those young kids who initially looked very sick but ultimately improved. So clinical pathways guidelines take up to 3 years to be fully implemented, and that we forget most of the time when we have the clinical pathways. We just sit in the air-conditioned conference room, we make the pathways, and we send it for implementation, but we forget who is going to use it, what's the situation there. Even small changes may have a positive impact, especially if the change involves an action that is repeated often, and that's what exactly I did. And I did it to an extent that now once I go to the ED, the first thing the nurses tell me is there is no acute bronchiolitis. So these are the steps that we took. February 2017, physicians were asking, where is the bronchiolitis pathways? And I talked to them. April 2017, no, I cannot use it. Did you involve me? I said that I did not involve you. Please come and sit with us. We will see that what you want. And then August 2017, thank you for your for the engagement. Can we change the pathway into physician order set? They said that I cannot use this pathway. It's too cumbersome. I said, okay, we'll make it into physician order set. it was too difficult to change the pathway into physician order set because the management of acute bronchiolitis is not on the standard lines. There are no medications involved. It's basically a conservative management. In September 2017, they say, I feel very confident. Now I'll use this. Thank you for involving me. So clinical pathways assure quality and safety and efficiency in the much needed coordination in a busy clinical setting. They improve patient care, consistency in the management so that both physician and patient feel confident. Achievements, development of a locally owned clinical pathway which in RSS, please don't have any clinical pathway unless it has been owned locally. You have to modify it, keeping in mind the local situations, local scenarios, local stewardship, local expertise. You have to have engagement of all the care stakeholders. Without that, your clinical pathway is not going to succeed. Motivation of staff is very important. I was there for 4 hours, 5 hours, 6 hours with the physician just to see that he gets some confidence. Awareness and knowledge about clinical pathways, acceptance and change in beliefs and behavior. Unless you do that, clinical pathway is not going to succeed. We created an environment of trust and mutual respect, professional autonomy, improved communication, and enhanced organizational support. We have yet to harvest. The data will come by the end of this year and April next year. But 3 children, which we saw in the month of October, they didn't have any chest X-ray or respiratory swab done. Acute bronchiolitis is a seasonal disease. The patient will start coming from November onwards. So the disease season is from November to April. That was our team. Thank you.
So my name is Chantal Ansel. I'm a family doc, and my goal is to reduce the time to psychiatric consultation using a shared care model, and to set the stage for the need to change how we practice medicine. Essentially, we're going to Carla's going to hopefully help me show a short video. Yeah. I'm going to get a chair so I don't pass it.
Physical therapy, the nurses. We're all specialists now, even the primary care physicians. Everyone just has a piece of the care. But holding on to that structure we built around the daring, independent, self-sufficiency of each of those people become a disaster. We have trained, hired, and rewarded people to be cowboys. But it's pit crews that we need. Pit crews for patients. There's evidence all around us.
Thanks, Carla. So essentially, there's a lot more to that talk, but I tried to sum it up in this slide. In 1937, there was a few tools a doctor had in their toolbox. They could bloodlet, they could poison you with mercury and arsenic to get rid of your syphilis. Now we have a much bigger toolbox with thousands and thousands of procedures and meds available to us. Thus, the pit crew analogy. Okay, where do I need to point this? Failure. Oh. Okay, there we go. So just a visual of the pit crew. So with that background, onto my project. So if you could advance the slide, Carla, for me, thanks. This will have to do it the old-fashioned way. So I work at the Student Wellness Center at the University of Saskatchewan. We see a lot of mental health related illness. In fact, most of our diagnoses are mental health related. We are a designated primary health care site, so as such we have a multidisciplinary team that includes primary care providers, counselors, psychiatrists, and since October we have a mental health nurse. Next slide, please. The old way, what Dr. Gawande in the video was calling the cowboy way was, and we're all familiar with this, GP sees patient, decides specialist opinion is needed, so you send your referral to psychiatrist. Okay. The specialist triages the patient to the wait list, and the appointment is booked 4 to 5 months down the road. And then you, as a primary care provider, and the patient manage mostly independently until the appointment, with the help of the Emerge Docs and the Dubé Center for those who end up in the hospital while they're waiting. So my goal was, how can we bring these, we have all the pieces in our clinic to bring together, how can we do it in a better way to reduce that wait time? So you can change the slide there. So, so really quickly, my husband didn't understand this slide, and I thought it was totally obvious that we want to be the Avengers, and you know, that's my pit crew analogy for myself, and I obviously was the lone superhero here, Black Widow, that's me. Oh, shush. I thought it was so obvious, but anyway, so the idea was, let's be the Avengers. Will it reduce wait times? Will it improve patient care? Will patients and providers be happier? And let's see if this actually works. You'll have to come to my poster to find out. And my analogy quote is, I have to remember here, we're all superheroes, but let's combine forces to do the most good. Thank you.
Good morning. My name is Erin Hamilton. I'm a family physician in North Battleford, and my quality improvement journey led me to attempt to increase the offers of HIV tests that are offered in the Battleford. The current state is that Saskatchewan has shockingly high HIV rates. We know that testing is the first step of having people living with HIV enter into the treatment cascade. We know that simply testing, increased testing, has been associated with decreased transmissions of HIV. And we know that HIV testing is cost-effective. And we have strong guidelines that emphasize that patients presenting for primary or emergency services who do not know their status should be offered a test. So, like Coco, I thought, hey, we've got an effective solution to a known problem. What could possibly go wrong? Our team enthusiastically set a goal of increasing the tests by 50% by November of this year. We started out by trying to learn a little bit more about provider knowledge, attitudes, and beliefs. We did a survey and spoke to different providers in the city, and we found that physicians and NPs basically did feel that HIV testing was important, but there were barriers. Most commonly listed were time constraints, lack of familiarity with pre-test counseling, and lack of familiarity with the referral process for positive results. We did find that 95% of providers would be more likely to offer testing if there was a policy in place for follow-up. And the emergency room staff were very succinct in their concerns, and that was time for counseling, the follow-up of positive results, and the more philosophical role of should we be offering a non-emergent test in an emergency care setting. So armed with that knowledge, we were able to go on and develop some interventions. The first thing was to develop a policy and procedure that details how positive results will be followed, specifically when the ordering provider is not the primary care provider. We slightly modified the patient information sheet put out by the province to be a little bit more applicable in routine testing situations. And we made sure the providers were familiar with this as an efficient way of providing good pre-test counseling. Our walk-in doctors jumped right on board and started offering HIV tests to any patients that they would be sending for blood work anyways, and they found that the patient acceptance of the test was really good. Our emergency physicians will be offering HIV tests to patients having blood work done, and our general surgeons will be offering HIV tests when booking patients for elective surgery. So we didn't quite meet our stretch goal of 50%, but we have seen an increase. But from this run, you can see that this is still a very unstable process, and we need to do a little bit more work to learn a little bit more about the causes of variability. But I do want to highlight our HIV testing superstars in this case is our walk-in clinic docs, who have done a fantastic job of offering the test. What's next is to establish some standard work for the ER surgery and inpatient medicine, as we're still in the PDSA kind of phase for those areas. Continue to find opportunities for testing in primary care. We want to monitor our balancing measure, and that was to ensure that patients who do test positive are connected to care and receive appropriate referrals. And we want to learn more about the factors that influence patients in either accepting or declining the test. But I can say truly that the past year was not just about HIV testing. I learned so much about communication, teamwork, and that changed the way I look at my daily work and the system that I work in. Thank you.
Good morning. I'm Mark James, one of the ICU doctors in the city, and work in anesthesia as well. The format of my presentation is somewhat of an elevator conversation. So I've limited myself to, I know it's elevated for 30 seconds, but I've got about a minute maybe to talk around, maybe a little longer. My project was related to sepsis, and it sprung out of the health, the safety HOSHM within the city, within this health region. And it's a pre and post study looking at if an early warning system, which is implemented within the RUH ward, the 5,000 surgery ward, makes a difference with implementation of standard guidelines. Regrettably, I don't have the post follow-up data. However, the pre-data would suggest that our surgeons and that ward have an awareness that exceeds or is better than the general population, physician population. And as a consequence, I'm uncertain there's going to be any significant change by the implementation of any other guidelines beyond what currently exists. At this point, I'm going to step away from that, mic, and happy to answer questions thereafter. Thank you.
I guess that means the rest of us have a little bit more time. So I'm Philip Wright. I'm a radiation oncologist here in Saskatoon, and my project was on looking at optimizing the use of a single fraction of radiation therapy for painful bone metastases compared to multiple fractions. So there's been many studies that have been done in a randomized setting. There's been systematic reviews which have shown that a single fraction of radiation treatment can provide similar results to multiple fractions for palliation of painful bone metastases. So what this resulted in the United States with the American Society of Therapeutic Radiation Oncology, they developed an evidence-based guideline in 2011. There's been updated systematic reviews, and in 2014 in Canada, the Choosing Wisely Canada released recommendations specifically for radiation oncology about using a single fraction for uncomplicated bone metastases. So in 2016, the Canadian Partnership Against Cancer, it released a spotlight report looking at quality and sustainability in cancer control. And it looked at 7 cancer screening and treatment practices, one of which was the use of a single fraction of radiation therapy for painful bone metastases. So on this slide, we can see that in BC, their rates of what this graph is showing is the use of multiple fractions. So 40% in BC were receiving multiple fractions, and then some of the other provinces reporting were more up in the 60–70% range for multiple fractions. And with this, they identified the desire to have a pilot project to be able to identify ways that you can increase the use of a single fraction in your jurisdiction, of which Saskatchewan and Manitoba were chosen. So just to give an example of where this is appropriate, this is a patient of mine that has received treatment over several years from metastatic prostate cancer. Initially, he received a single fraction here. Later last fall, he had the bone metastases progressed where he was having compromise of the spinal cord function and had surgery, and so received 5 fractions to this area here. That's a complicated treatment or complicated bone metastases. And then he's also had single fraction to the pelvis. This is the bone scan showing an increased uptake as a result of his prostate cancer in the bones. And earlier this fall, he was having increasing pain in his left shoulder. So even though all these areas show that there's bone metastases, they're not all necessarily where he's symptomatic. So what this diagram is showing is that we planned out giving radiation to his scapula in the area where he's having pain. For this patient, he lives 2 hours away. So with multiple fractions, either 5 treatments or 10 treatments, if he was not able to stay in Saskatoon for his treatments, there's obviously a lot of driving involved. So historically, for our use of multiple fractions in the province, in Saskatoon specifically, this red line is our average as a group, and all the different colored lines represent the individuals who and how many. So overall, future steps are to share this information in develop ways that we can increase the utilization, make it easier for people to choose what's appropriate for patients. Thank you.
Good morning. I am Rabia Shahid. I am journal internist in Saskatoon, and our project was to reduce unnecessary testing before surgery. I work in the pre-op clinic, and I have been working it for a few years and realized that every day we are doing testing which is not necessary. Preoperative testing, we know that rarely change management. It can cause harm to the patient. In one of the studies, they found out that up to 93% of the testing was not necessary. And Choosing Wisely Canada also recommends against routine pre-op testing, and also other societies like Canadian Society of Anesthesiology recommends against routine testing before surgery as well. So in order to find out how we are doing in Saskatoon, we gathered a team of expert stakeholders, representatives from different departments and areas. We wanted to conquer the world in the beginning when we got together in our first meeting, but we decided to focus first on a subset of the patients, on patients going for hips and knee surgery, and those patients who are going for elective surgery. So to understand a journey of a patient, we did the process mapping to find out where those pre-op testings are being done. And we found out that there are few places there, and I'm sorry for the small font here, but there are, and it's the yellow part that we are doing the pre-op testing was done and was being done before the surgery. For the patients going for hips and knee surgeries, we found out that most of the patients are going for the pre-assessment clinic in Saskatoon, and most of the testing is being done in the pre-assessment clinic, and some of those tests are unnecessary. We wanted to find out why those unnecessary tests were being ordered. I will not go into detail of each cause over there, but we thought that the few most important reasons were lack of awareness of the guidelines and recommendations, and also lack of a standardized tool or protocol to guide patient-specific testing according to medical profile and a medication profile. So Dr. Edward Deming, he's considered as a founder of a quality improvement. He said that in God we trust, all others bring data, which could be very challenging to do it sometime. We managed to get the baseline data. We found out that 35 to 91% tests are not necessary, and there's a huge variation because some tests were ordered more than the others. We developed a new process to get the testing done in the pre-assessment clinic in City Hospital for a subset of the patients going for elective hips and knee surgery. Our aim was to reduce unnecessary testing before surgery by 50% in that subset of the patients. We saw that the reduction was done after that process was implemented by 68 to 82%. So we did it. I will not declare that triumph, but this was our first step towards the improvement. And if you want to know more, please come with my poster. Thank you.
So good morning. My name is Dr. Shakil Kurma. I'm one of the infectious disease specialists in Saskatoon. This is supposed to say 30%. Sorry about that. If we look at inappropriate prescribing in intensive care units, 30% of antibiotics prescribed in ICUs are felt to be unnecessary or inappropriate. And this is often related to prescribing of therapies that are too broad, too long in duration, and representative of contaminants or colonizers that are not truly an infectious process. When it comes to prescribing behaviors in an intensive care unit, it's quite complex. You're looking at various organizational characteristics, social interactions amongst clinicians and between clinicians and patients, as well as a lot of emotion and fear. When we're looking at antibiotics being prescribed in an ICU, it's very tricky. It's a high acuity environment with critically ill patients. There's minimal room for error. We're starting to see the emergence of multi-drug resistant bacteria in our ICU population, and we also can't afford to miss an infection. But we also know that antibiotics are not benign agents, and we know that inappropriately prescribed antimicrobials can drive resistance, as well as increased risk of adverse events, toxicity, and C. difficile infection. We also know that inappropriately prescribed antibiotics can increase morbidity and mortality. Thus, we need effective strategies that are tailored to the critical nature of patients admitted to ICU, but also promote a collaborative nature in our ICUs that promote judicious antimicrobial prescribing. Thus, I'd like to introduce the concept of handshake stewardship. This is a concept related to antimicrobial stewardship and prospective audit and feedback that emphasizes verbal, face-to-face communication and collaborative nature between ICU and antimicrobial stewardship. We implemented this strategy in Royal University Hospital Intensive Care Unit, where myself and our antimicrobial stewardship pharmacists met with the ICU team 3 times per week in person, Monday, Wednesday, and Friday, and discussed all patients actively receiving antibiotics, and then in turn provided recommendations to the ICU team. We categorized all of our different antimicrobials based upon their spectrum of activity and coverage of multi-drug resistant organisms. And then we looked at monthly usage of narrow spectrum, broad spectrum, and total antimicrobial use in the ICU on a monthly basis using daily defined doses, standardized for the number of ICU patient days. In terms of the types of recommendations made to the ICU, we categorized these. And over the past 9 months, 70% of the recommendations we provided to the ICU revolved around discontinuation of therapy, de-escalation of therapy, and duration optimization. Sorry, this is incorrect. So this is supposed to say 319. So over the last 9 months, we reviewed 319 patients. We provided 229 recommendations to the intensive care unit team, and our overall acceptance rate was 90%. We also surveyed the critical care staff to find their opinions and their attitudes and perceptions towards these rounds. 86% felt that these did not impede upon their autonomy. 93% preferred this model involving face-to-face interaction in a formalized setting, and 86% felt that these rounds improved the quality of patient care. And so if you'd like to know more about how we impacted usage of broad-spectrum antimicrobials in our ICU, please come visit my poster. Thanks.
Good morning. All right. I'm Maurice Sojak, one of the general surgeons in town over here. And my project was essentially focused on looking at unnecessary ultrasounds in the diagnosis of inguinal hernias. So inguinal hernias are fairly common problems. Basically, there's a lifetime risk up to 25% for men and women, majority being men, but they do often happen in women as well. Frequently, we get referrals from general surgery from our family physicians, and often these do come with an accompanying ultrasound. And typically, inguinal hernias are fairly easy to detect on clinical examination, especially if they're larger ones. And we find from the surgeon population that the ultrasounds rarely influence what we do with them at the end of the day. If there's a palpable hernia, we often will suggest getting it fixed if required. And if there's no palpable hernia, often we don't provide an operation, or we don't offer an operation. So my idea was that perhaps we could reduce the number of unnecessary ultrasounds and therefore hopefully save both patients and the healthcare system time and some expense. So this is just a little slide to horrify you for the morning. But basically, you know, to just illustrate the point that inguinal hernias come in a variety of sizes. This is quite a subtle one. It's a more obvious one, and you can't miss that. So they certainly come in a wide variety. So the objectives essentially were to first estimate the proportion of referrals to my practice in which patients had clinically detectable inguinal hernias that had an unnecessary ultrasound accompanying the initial referral. And then once we had that data, communicate to general practitioners that an ultrasound is not necessary for clinically palpable inguinal hernias. And then finally, kind of record the data and detect a change in the frequency of the ultrasounds that are accompanying these referrals that are sent to me. So I essentially used a retrospective chart review. I didn't make an attempt at getting my other surgeons in the group to join in, but they were a little hesitant at first or difficult to get a hold of, so I essentially just made it a practice audit to start, and then we'll see if we can roll it out to them later. Once the data was completed, we sent a letter to the GPs that referred to me anyways, kind of outlining the process and just suggesting that if they had an obvious hernia, they did not need to send an ultrasound. So that's gone out. And we are ongoing with the measurement of the referrals that are coming in. It's only been out for, the letter I think has been out for a month or so, so I don't have any robust data yet. So just looking at my own data, the pattern of hernia referrals in my practice, so basically for total in 2016 when I reviewed all the data that was coming into me, I had 49 clinically palpable hernias and 18 occult ones, meaning that people were sent in probably for another reason. Groin pain would be the most common, and they had an ultrasound attached saying there was a hernia there, but nothing obvious on palpation. So the majority of the referrals I get are actually for fairly obvious palpable inguinal hernias. And then when you look at the number that are actually clinically detectable, those that actually came with ultrasounds, almost essentially a third of them came in with an ultrasound that probably wasn't really needed and didn't change anything, and then 2/3 were just sent in with the clinical diagnosis. So if you extrapolate that using our fee structures for billing for ultrasound interpretation, essentially it's almost $90 for a radiologist to read an ultrasound of the groin. And if you multiply that by the number in my practice alone that for the year that we could have saved, it's roughly about $1,600. And then take that out to all the general surgeons in town here alone, we can almost save maybe up to $20,000 a year or so in ultrasound costs, which I think is a fair reduction. And if you have want any more information, stop by and see me afterwards.
So my name is Naroshan Silverwing. I'm one of the general surgeons in town. I'll warn you now, I don't have any of these gross hernia pictures that Dr. Ojak put out. So my project was on VT prophylaxis in post-op cancer patients, and are we doing enough in this province? This has been studied for the last 15 years or so, and there's lots of data. These are all North American and European data, and the evidence is clear, and everyone says the same thing, that we should be sending our post-op major cancer patients home on 4 weeks of VTE prophylaxis. It's safe, it's effective, and it's well taken in many places in North America. Unfortunately not here. So the challenge is this. Currently we don't have a protocol in our health region, and I bet in the province, to make this happen. So we are currently failing Accreditation Canada's requirement on this, which means that we're also failing our patients and not recognizing the VTE risk in them. Unlike other provinces, Saskatchewan does not pay for post-op VTE prophylaxis in these patients, so the cost is on the patient. And there's a big buy-in. You need the surgical community, the pharmacology community, hematology, the health authorities, and the patient to want to do this. So calculating the risk, again, this has already been done for us. So when Joseph Caprini did this in 2005, and over the last 10, 12 years or so, has been very well validated. And we've got a scoring system that can categorize what sort of risk someone is in for VTE. So I don't know if you can see that, but that's our pointer. Right there. So you get 2 points for each thing. So if you're over 60 and you've got a malignancy and your cancer surgery is over 45 minutes, either open or laparoscopically, you get a score about 6. And if you go down to this chart on the other side, and then right about here, you can see you're fairly high risk. So your CAF DVT anywhere from 20 to 40%, and so on. So all the work has really been done for us already. Now the team, like a lot of my colleagues said today, I have to echo that and say, look, I started off with having a massive goal, but then thanks to this amazing team that we have, really brought it down to something very manageable and doable. So the method, we kept it simple. So if you're over 60 years old and you're having cancer surgery in the abdomen pelvis, and it's more than 45 minutes long, which is all typical cancer surgery, then you qualify. So what we did was from April to the end of June, we collected the baseline data, and the 2 things we really want to know is this. Was there a prescription on the chart for when they went home for 4 weeks of VTE prophylaxis? And that's something we collected on our own. And the second component to that is, well, did these patients actually fill the prescription? That was information we got from the Ministry of Health. So July 1st, we put an intervention into place, and then after that, from July to end of September, we collected similar data as before to see, well, did our intervention do anything? Our intervention was education and knowledge, and at the end of June, I went around and talked to anyone who'd listened to me about this and said, this is what we want to do. So, you know, the nursing staff, the educators on the wards, the physicians, the residents, out of time, all right. So results, come see me. I thought the results were actually quite interesting, and I have to thank my team, because without them, this would not be possible. Thank you.
I don't have a list in front of me. Has everybody had a chance to share? Okay. Okay, that's fine. Then this is our opportunity to just free range go and see posters. Grab a copy, take a little bit of a break, and then I'll ask the various participants to be by.